Hey everybody, welcome back to my new series, the Technologist Repair Shop, from Nope to Dope, X-ray edition. So, kind of a long name, but the reason I'm doing this is I'm taking images that have come off of our PAC system that have been taken in one of our 18 clinics. And I'm looking for images that aren't quite up to snuff, and we're going to talk about what's needed to bring them to a dope status, right? Make them diagnostic. So let's get started. I'm glad you're here with me today. I appreciate it. So here's our first nope. Okay, here we've got a foot X-ray. There's a couple of things here. First of all, I noticed that there's just two pictures. There's an AP and a lateral. So for all extremities, we're going to take three pictures, usually an AP or a PA, an oblique, and a lateral. Here we're missing the oblique. And I just want you guys to realize how important it is to get all three views. Because you may not be able to see something on the AP, but you turn that bone a little bit and you may be able to see a small fracture on the oblique, which could be missed if we didn't take that picture. So even if your provider comes and says, I need a 2-view foot X-ray, we're going to do a 3-view foot X-ray because that's what the protocol is, and that's going to make it more diagnostic for the provider as well as the radiologist, and ultimately for the patient. So here we have a left foot. Okay, we know it's a left because there's a marker on both images. The problem is the marker was in the anatomy. Have a marker obstructing any anatomy. I know it's a really small portion that L makes, but there may be a fracture underneath here or along this cortical right here that you wouldn't be able to see because the marker's in the way. Okay, those markers ultimately should be on the lateral side, so we'd have an L over here and we'd have an L over here, which is on the top side of the lateral. Okay, positioning wise, it's pretty good. It's a nice lateral. It's a nice AP as well. We're able to see good joint spaces. The periosteum looks really good. There's good denotation with the bone and the soft tissue, so it's easy to see if there's a disruption in the periosteum anywhere. So positioning wise, it's really good. Collimation wise, it's fabulous. Good job collimating nice and tight to the foot without cutting any image off, which is nice. Anatomically speaking, the AP right here is actually hung really well. Toes up. And the only problem with this image is the marker. Okay, and then on the lateral, it's actually a nice lateral. However, that the laterals be annotated so it's like that foot is sitting on the floor, so it's going to look kind of like that one right there, okay, versus straight up and down. The collimation is good, the contrast is great. So this is a nope, okay. We want to make sure our marker's out of the anatomy, and we want to make sure that our image is annotated correctly, which the AP is and the lateral is not. So here's a dope foot. I only included the two images just so we can compare to the two images that were given. We're again missing the oblique here, but I didn't copy the oblique. It's a nice foot as well. It's collimated really nicely. It's marked correctly out of the anatomy. Contrast wise, it's a nice picture. It's nice and sharp. You got good joint spaces. The periosteum is easily noted. And then on the lateral, we've got that lateral sitting on the floor like the foot's just sitting on the floor. So this is how your laterals should be annotated as well as the AP. So we got nope, marker in the way, dope. Okay, very good. You just know this is how your foot is going to look. Okay, when we're done, toes up for the AP and oblique, and the lateral, that foot is going to be sitting on the floor, facing the right direction for a left foot. Okay. All right, let's move on to the next one here. Okay, believe it or not, this is a C-spine. Okay. The first thing that jumps out to me is lack of collimation, and our positioning isn't great as well. It looks like we centered about T2 right here, where we should be centering up here around C3, C4. Okay, and we've actually cut a little bit off on both of them. Here we're missing C1 on the lateral, just because we've cut the anatomy off. We centered way too low. So but that's an issue. Okay, and also this AP, you'll note that it's kind of washed out, kind of light. Your sharp edges aren't as sharp, and that is totally due to the lack of collimation. You're surprised if you collimate to the C-spine, we're going to get from the top of the ear or the ear hole all the way down through probably T3 or T4. Okay, so we're going to get this area up here. Here's the top of the ear right there. But we're going to cut our collimation off about right here. Okay, and we're going to collimate nice and tight to the neck lateral borders. Okay, it's marked well. It's left. It's marked as an AP, which I really like. It's a very good job there. Now the lateral, we're centered a little bit too low. Like I say, we're cutting off C1 right here, so we don't have no idea what's going on up here. Now if we put the top of our 10 by 12 image size at the ear hole or at the top of the ear, you're going to catch that C1 every time. Okay, and it's kind of hard to tell what's what. I mean, we got the spinous process. I'm thinking this is C7 right here. And 7, 6, 5, 4, 3, 2, 1, and we're missing 1. Okay, it's marked well. It's actually a pretty good picture contrast-wise, but the collimation again is just way wide open. Okay, we need to collimate to our body part. Let's skip on to the dope one here. Here we've got a lateral and an AP. And you'll note that the collimation is much better on this one. Okay, here's, you got your mastoid air cells right here. Here is the EAM, the ear hole. So we're top of our film was up there near the top here, which is where we want it. And we've opened to a 10 by 12 basically, and we've collimated to the anterior and posterior aspects. And we picked up down here as much as we need to. So actually this is collimated really nice. And you'll note that the contrast on the collimation or the collimated picture is much better, much sharp edges. We're able to see soft tissue really well. You've got air coming down the trachea right here. Here you have the epiglottis. And the hyoid bone right there. But you can see air going all the way down to the lungs. But yeah, as far as positioning goes, it's very nice. And one of the ways you can tell that is your anterior arch of C1 is right there. It should make a D, a capital D right there. So again, that's the anterior arch of C1. And then you've got the backwards D right here, which would be the posterior arch of C1. So we know that this is C1, okay? We've got the anterior and posterior arch, and they look like a capital D. So we know that we're really good rotation-wise. We got a good sharp, nice curve to the C-spine right here. Good joint spaces. Really nice. We've got this spinous processes coming out. We've got 1, 2, 3, 4, 5, 6, 7, and we actually can see T1, 2, and 3. This is a really nice C-spine. If you ever get confused on what's, find the anterior and posterior arch of C1. You know that's C1, 2, 3, 4, 5, And I don't know what I did there. 6, 7. Okay, we need to be able to see 7 cervical vertebrae on the lateral, and it's good if we can see T1, which can be challenging sometimes, especially on a bigger patient. But this is a really, really nice image. So we went from that lateral right there, where it's wide open collimation, and we've cut the top off, and here we've got the good lateral, right? Yeah, it's a nice picture. It's marked correctly. It's out of the anatomy. Very, very good picture. And then we've got the AP over here. You can see the air pocket that's going down the trachea right here. It's kind of neat looking. Anyway, the AP it's a nice picture. It's collimated perfectly. It's marked perfectly. We've got good contrast. Here we can see C2, or the odontoid process right here, going up into C1. So this is 2, 3, 4, 5, 6, 7. Okay, and you'll note down here on T1 we got kind of a bolt-looking thing coming off the side of the vertebrae there, and of course the ribs starting to come off of T1. But yeah, good joint spaces. Contrast is good. Good differentiation between soft and bone. So this is our nope. Okay, collimation way too far open, and we're not centered very well. It's marked, which is great. Okay, then we've got what it should look like ultimately when you take a C-spine. And you guys don't get frustrated about stuff like this. It's a learning process. When you first start out, you're gonna be happy that you got the body part that you're actually trying to shoot. But once you get to the point where you are centering correctly and you're getting what you want to get, you just start working on your collimation. You can see that our collimation lines are pretty close to the lateral skin margins of the neck. And if you can collimate to the lateral skin margins of the neck, and then just keep your long axis to 12 inches, you're going to get everything that you need to get. Okay, so good job. So this is a dope C-spine. We are gonna, I didn't put all 3 of the views, but I put the odontoid next. So the odontoid, we need to make sure we're shooting odontoid on every C-spine that we do. Okay, it's imperative that a provider and radiologists see, the C junction right there. You'll note that this is really, really wide open. So to collimate for an odontoid, you're basically going to draw a square over the open mouth, okay? And that's all the collimation you need. This one is just wide open and needs to be collimated. You'll note that the X-ray is kind of washed out. If you were to collimate that, a sharp image. So but yeah, so we can tell that the head is turned a little bit to the right. You can see that the head is kind of cockeyed, where the dens right here, the odontoid process, isn't in the center of the mouth. It's kind of off-centered. And we've also got the upper incisors right here that are covering the tip of the dens right here. We do have good zygapophyseal joints, the joint space between C1 and C2 right here. And we've also got the lateral, we can see both of them. It's just kind of off-centered, and we need to tip the patient's head back just a titch so we can get these incisors out of the way of the actual odontoid. Okay, and there's no marker on this picture, so we don't know what's right and what's left. So very, very important that we mark these images, and it's easier to do pre-processing because you know what side's right and which one's left, right? So we could have a left marker or a right marker over here, or a left marker over here. Okay, all in all, it's not a terrible picture. It's just a major lack of collimation, and the head is just tilted, or not tilted, but turned just a little bit to the left. So, ideally we want that odontoid to be right in the middle of the mouth. Okay, so let's look at the dope odontoid picture. Now you'll note that we're collimated much better this time. We've basically collimated to the open mouth, right? We can still see the upper incisors and lower incisors right here. However, we've got the tip of the odontoid, we can see it freely, which is really what we want to see. The zygapophyseal joints are well displayed, nice and open. And then you got your lateral masses here, okay? And it's right in the center of the mouth, so we don't have any rotation, okay? We're starting to see a bifid spinous process right here and right here. Right here, spinous process. Okay. This lower margin right here is actually the inferior articular surface of C1, and then you've got your superior surface or articular surface of C2. Okay, so when we're shooting our odontoid, just make sure you're collimating to the open mouth. Okay, you don't need much more than that. Make sure that the head is facing straight forward, and you draw a line from your ear hole to your upper incisors. It should be a straight line, and have them open their mouth as wide as you can. And most of the time that dens is going to be right in the center of the open mouth. And this one, honestly, guys, takes a lot of practice. I've been doing this for 23 years, and every once in a while I'll still miss one. But practice. This is a picture that you can take pride in, one that you'd be proud of. Anytime you get this picture correctly, like this one right here, and it's something to celebrate, really, because it does take a lot of practice. But just work on collimating on your odontoid, and make sure you're taking your odontoid picture on every C-spine series. Okay, so we went from that with no collimation, no marker, head's a little bit turned to the left, to this one where it's collimated really nicely, and all the spine or C-spine that we need to see is present, all the way from the tip of the odontoid all the way down here to the base of T3, right? And the incisors are out of the way, and it's a nice crisp picture. It's marked with an R, so we know which side's right and which one's left. Okay, well, I hope you guys found this a little bit not entertaining, but educational on what you need to see on certain x-rays. And I'll be putting one of these out each week, and we'll go through different images that I come across that may need a little help. And hopefully you guys will take this information and use it in your clinical days when you're doing x-ray, and just work towards the best, most diagnostic image you can. Remember, we're not trying to do our patients any disservice by shooting a non-diagnostic x-ray, but it's so important that we practice and shoot a diagnostic x-ray for them, for the provider, for the radiologist, and for us, so that we can sleep at night knowing that we didn't miss anything. This is all about making corrections, guys. You get a picture that comes up that doesn't look quite right, and maybe you've cut part of the anatomy off. You do need to retake that picture and improvements every time you do it. It's not always going to be perfect, but it's something to work towards. Anyway, hope you guys enjoyed this. We'll be back next week with some more images that we can kind of go through and see what it shouldn't look like versus what it should look like. So anyway, thank you guys for being here today. And as always, please give me a call if you need any help or any guidance or anything like that. I appreciate y'all. You're doing a great job. We'll talk to you soon. Bye.